important papers in terms of prevention with Gunnar Johansson, and this is prevention in allergy and asthma. I think that this is a milestone document in this area. Taril is coming from Helsinki, and unfortunately in the program Helsinki was quoted in Norway, so I hope next time, since I'm invited to come to Helsinki for your National Society meeting, please don't put me Genoa, Spain. I wouldn't like it. Okay, by the way, Taril. So today you have to talk about asthma as a systemic disease and the clinical aspects, please.
Good day everybody, and ladies and gentlemen, dear colleagues, and the three musketeers, Walter, Leo, and Sergio, my good friends. I'm very pleased to have this opportunity to talk to you and share some new, pretty exciting new things what we have found in, not in Norwegian, but in Helsinki, Finland. But I'm not only focusing on the systemic aspects and the direct clinical relevance for the treatment. I will start a little bit with epidemiology. In fact, if we get this oh, I think so. It's coming.
I understand that in Scandinavia there are jokes about Norwegians. It was not because I'm responsible of the leaflets, even if I didn't review it properly. It was supposed to be a joke.
Okay. Okay. Here you are. We are just having snow in Helsinki, and this is Skin and Allergy Hospital, which is part of the Helsinki University Hospital, a little bit separate building from the main hospital, and we are housing there two departments, Department of Allergy and Department of Dermatology. Leo, do you recognize this picture? It comes from Padova, and of course the very, very famous lecture room, and this is around 18 years ago, and Leo, you look very young there.
Thank you, Tari. Thank you.
But you still seems to be going so strong that I think that after 18 years we will again have a nice meeting, Modena, Ferrara, Padova, or somewhere in this beautiful Italy. Well, they have quite an interesting tradition in Padova. They have put all their professors of anatomy in that box, and I think that's a interesting way to preserve the best part of the professor, not only to make the dull portrait on the wall. I'm touching the epidemic of asthma and allergy, and then I will highlight the inflammation as a systemic response, but also would like to share some ideas about the new things in genetics, and kind of a challenging that comorbidity of asthma and rhinitis is of course important, but it's also very, very important in the clinical terms, because it's a sign of severity. And then I will focus on some of the data, very new data, on the Finnish asthma program, which we have just finished the final 10-year document, emphasizing the point that we really should treat all aspects of inflammation and do it early. But let me first take you to the Karelia area. So Helsinki is here, and now we go to the southeastern part, to Karelia, to the Russian Karelia and the Finnish Karelia. The study sites for this epidemiological survey was, they were only 100 kilometers apart. So very near each other, in fact. But the conditions, the environmental conditions and the lifestyle and the standard of living, they are completely different. And we have been comparing the allergies and trying to explore the reasons for the higher number of allergies on the Finnish side. Well, what is this building? What would you guess? It's a health center in Russian Karelia, year 2000. I think it gives you an impression that this is really one of the poorest corners in Europe. And another example is that the life expectancy for men is 54 years, while it is in Finland 75 years. They smoke too much, they drink too much, they have a lot of violent deaths, and they have all the health risk factors. I'm not saying that we sometimes also in Finland take a few drinks, but anyway, they take a bottle. I must tell you, they have all the health risks, but they are not allergic. And let's look at the objective data. We have the IgE data, we have the skin prick test data, which are not influenced by the better health coverage. And let's just focus on birch pollen allergy and sensitization, which is the most important allergen in the Nordic countries. So on the Russian side, and now we are speaking about school children, on the Russian side, the sensitization rate to birch pollen is 2%. On the Finnish side, it is 26%. And there is only 100 kilometers apart. Well, let's look at their mothers, because at the same time when we tested the children, we also tested their mothers with a mean age of 37 years. And 6% of the mothers are sensitized, which is normal, that a bit more in the adulthood and the young adulthood is sensitized. But what happens in Finland? We come down from 26% to 14% in the mothers, meaning that on the Finnish side, the children are more sensitized than their mothers, when it's the other way around on the Russian side. This is really showing me that there is an epidemic going on in the Western world, in the urban world, in the more affluent world. Well, I think it would be of interest to you that at the same time another Finnish group has made a study about another chronic systemic disorder, and that is type 1 diabetes. And there is a four-fold difference. It's the same kind of difference what we found in allergies. Well, we have tried to explore, and we are just really starting these studies, what might be the reason, what are the environmental conditions which are exposing the people so differently. So we have been collecting dust. And I can tell you that when we took these dust samples from Russia to Finland, the officials at the border, they look a little bit surprised when they found out. They make a very close survey of what we are taking from Russia to Finland, and they found that we are taking dust. Where are the gold? Where is the diamond? Where are the diamonds? Where are the drugs? Dust, are you crazy? Okay, I made some comparisons, but I just show you that, well, we have been talking about the endotoxins and the liposaccharides, lipopolysaccharides, that they are very important in driving the innate immunity. They probably are, but when we look at the barn dust samples, and this is done with collaboration with microbiologists, the gram-negative bacteria, they compose only 10% of the total bacterial composition. I claim and I suggest that it's the gram-positive bacteria which are much, much more important in driving the innate immunity than the gram-negatives. With chemical markers, we can also look at these different groups by ergosterol measuring the modes, by hydroxy fatty acid measuring the gram-negatives, and muramic acid the gram-positives, and that's what we are doing. We also have an animal model, a mice model, and here are some very preliminary data, that if we put the barn dust or the urban home dust if we expose the mice with different kind of dusts. The pro-inflammatory pattern which is created is very, very different. And here you see how the green bars here, how the pro-inflammatory cytokines, the IL-1B, TNF-alpha, MIP-1, and toll-like receptor 2, they are all expressed much, much more with the barn dust, which is very, very biodiverse in terms of the bacterial and mold components. So it's really a big difference of these dusts, how they are driving our innate immunity. A third Finnish group in Turku, Dr. Viinanen and co-workers, it's just coming out from allergy, this paper. She spent 1 year in Mongolia and look at the allergy and asthma in Ulaanbaatar and also in the very poor and farming yurta societies, and found out that the best protection was given by the close connection to cattle and cattle dung. And the ladies there, the women there, they collect the cattle dung, they dry it, and they use that for warming. Altogether in Mongolia, the prevalence of allergy and asthma is very, very low. But it is higher in Ulaanbaatar than here in the yurta societies. So, well, what is it the cattle or the cattle dung which is protecting? No, it's the microbiota. And it's very interesting that when these protective factors, which seem to be associated with the exposure to the microbiota, when they start to vanish, when they start to disappear in more urban communities, then the risk factors, they start to play a role. So she found out that DOC, for example, is a risk factor for asthma in Ulaanbaatar, but not in the rural yurta community. Well, let me then go to the inflammation as a systemic response, which is manifested locally in, as asthma and rhinitis. If the innate immunity is driven to the wrong direction and the person is sensitized and then is re-exposed, let's say, to perch pollen, then we see this intruding of inflammatory cells because of chemotactic factors. They are intruding from the vasculatures, from the small vessels under the lamina propria, for example, in the epithelium, through these endothelial cells. There are small gaps between the endothelial cells, and these cells, inflammatory cells, are intruding through the gaps because there is a vasodilatation, and they are influxing to the epithelium and even the bronchial lumen. So I think when we are speaking that there is inflammation and there is remodeling and there are the lung function abnormalities, well, I have the opinion, and very much so, that it's always the inflammation which is first, and the lung function abnormalities, they are always kind of a complications. They are consequences and complications of that inflammatory response. This is a patient example, my own patient. He had symptoms only for 2 weeks. And already had some lung function abnormalities, but he was not showing increased bronchial responsiveness at that time. It was a very early stage of the disease. So, but you see that there is a great influx of the different inflammatory cells like eosinophils, neutrophils, lymphocytes, and all that in the subepithelial tissue and in the epithelium already at this 2-week stage. Go further. Let's.
Abbiamo un problema con la diapositiva, non procede.
If you can make the next one, that would be very nice. But anyway, okay, there you go. Okay, and well. As a consequence of all this, you see these patients in your office. And here is 8-year-old Sauli showing severe conjunctivitis, nasal blockage, mouth breathing because the nose is so blocked, and also wheezing. And he came to me and said, said that, Papa, can you do something? I feel miserable. I hope my treatments have been right, because now he is a grown-up young man and a dentist and doing just fine, so I'm happy. But I think really that my impact in that treatment was not that good. There was a natural recovery, which often happens with these young people. Well, anyway, if you think about the asthmatic and allergic inflammation, it's a kind of a general inflammatory response where many cell types play a role. This is an old study which shows how the different cell types are increased in asthmatics compared to normal controls. Not only eosinophils, which are of course very characteristic to the asthmatic inflammation, but also the numbers of mast cells, neutrophils, lymphocytes, and macrophages. They are all increased. But the problem from in clinical terms has been that we haven't got the handy methods to detect the inflammation early enough. We have kind of measured the consequences, the complications, the lung function problems. But the inflammation may have been there for years, not on a persistent way, but periodically, before the lung function starts really to react in an abnormal way. But now we are having new possibilities, and this is one. The exhaled NO, there's a new portable device. One measurement costs about €8, and that can be used in your office practice. Also, we are developing a quick induced sputum test, where we could specifically identify whether an eosinophilic or neutrophilic inflammation is going on. So we are having the tools to detect the problem earlier than we have used to be. Any news from genetics? We see the symptoms, the asthma rhinitis symptoms. We can measure the peak flows, we can measure the hyperresponsiveness, and we know that there is the inflammation going on in background. And we are starting to be able to measure also the inflammatory parameters. Better than ever. But then we have to go back one step and think what is behind that inflammation. There is the genetic disposition and the various genetically determined molecular pathways. What are they? In fact, the picture is pretty fuzzy at the moment. Almost half of the chromosomes seem to possess some genetic factors which are associated to increased asthma and allergy risk. From the clinical point of view, asthma and rhinitis is kind of an umbrella diagnosis. It's one phenotype, more or less. But then the genotypes are very, very variable, and we are just at the edge of learning what is this meaning in clinical terms, this biodiversity of these genotypes. In Finland, the Finnish group has found the so-called GBRA gene, which is associated with atopic asthma and associated with increased IgE levels. While another example is ADAM33, where Professor Holgate and co-workers, they have found that it's more associated to the metalloproteinases, the smooth muscle, and maybe the remodeling process. So we are learning gradually, but this is just the beginning. The Finnish gene was expressed very heavily in the two major players in the asthma pathophysiology, namely in the epithelium and in the smooth muscle, when the protein was immunostained. It does not, if you have an expression of this gene, it does not increase your asthma risk very much. It increases the asthma risk around twofold. But it seems to play a very essential role once the inflammation starts. Then it seems to be very active in that process, which may give new opportunities to intervene also with new kind of treatments. But then we have the very, very crucial question. What are these genes doing really? This is just description and associative studies to say that this is associated to something else. But what are these genes doing? Kinen and Rytilä in this Finnish group, they have found out that probably the Finnish GBR154 gene is associated and is really changing the function of macrophages. The macrophages, and here it is very much expressed in the macrophages in the induced sputum cells. What are these macrophages? What is happening to the macrophages? They are coming, in a way, more aggressive. I have taken an example that, well, if you, they are kind of a bunch of unemployed young men who are rioting in France and burning cars because they don't have anything to do. All the problems in the world, they are caused by the young men full of testosterone and nothing to do. So I made this comparison that maybe it's this gene which in different environments are acting differently. They are becoming more aggressive. They detect the kind of innocent bystanders like pollens more readily and start the phagocytosis more readily and the immune response more readily when the snowball starting to go on. These are very, very new data which are now in press, and we'll see what is the truth. But it's also a very, very interesting observation that this expression of the gene is in the urban communities and in the urban populations. When you go to the rural Mongolia or you go to the Pitcairn, to the Russian Karelia, it doesn't seem to work there. So it depends on the environment. It's all the time the gene-environment interaction, and we really don't understand very much about this very complex issue. There is a large pan-European study, so-called Gabriel Consortium, starting now to looking more closely at the gene-environmental interaction. Well, Rome, 1967. Why am I showing this picture? For two reasons. There you see what the age, the years, what they do to a man. I don't know what they do to women, but they do something definitely to a man. But then there's another reason also, and that is the mid-1960s pinpoints the period when the epidemic of asthma and allergy really started to appear. And we have the data from the Finnish young men, and we published that in British Medical Journal last spring, showing that there is a parallel increase in asthma and in rhinitis from 1966 to 2003. And you see that the prevalences are quite low there at the 1960s, and something started to happen at the mid-1960s. Well, then the question is, what happened in 1960s? Nothing very special. I was in Rome and throwing the coin to the Fontana di Trevi, hoping to come back to Rome. But the more important question is, what started to happen when these young men were born? And that was just after the Second World War. Then started the public health programs of cleaning the water and starting really the antibiotic era, the vaccinations and whatever. At the moment, when looking at the dust samples in the Karelia area, I even think that the vacuum cleaners may be one reason for the allergy epidemic. This is challenging your ideas, sorry. Well, remember the comorbidity. Well, I take another issue here, because now it seems that this epidemic is somewhat leveling off. The numbers are not increasing like they do, like they did before. You have some data in Italy, there's some data from Germany, there is some data from UK, and we are also starting to see in Finland that this is it is probably a little bit leveling off. It just might be that our genes are adapting to the new kind of urban environment. And the epidemic is leveling off even before we really understood what happened. Well, let's go to the comorbidity. And I just would like to make one point, and that is that it is often really a sign of severity. And that is an important clinical message. And again, I go back to the Karelia data, which is in press now in Journal of Allergy and Clinical Immunology. So if you look at the children in Karelia, how many hay fever patients had also asthma? 28% of the Finnish children with hay fever had also asthma, while 0% of the Russian children. Probably because their sensitization is so mild, that this disease is so mild. When you make the question other way around, how many asthma patients had also hay fever? So on the Finnish side, 50% of the asthma patients had rhinitis. Well, on the Russian side, somehow 0. So if you have symptoms from the lower and the upper voice, it's a more severe disease than you think. It should be, like Sergio was saying here, it should be treated as a systemic condition. Then we also underestimate the bronchial symptoms our patients with rhinitis are having. And it is a very interesting study from Australia by Downey and co-workers showing that in rhinitis patients, in some way, in some time during the follow-up year, about 1/3 showed increased bronchial responsiveness, even though at the baseline they were not asthmatics, they were not diagnosed as asthmatics, but they showed in 1/3 increased bronchial responsiveness. And at some time during the year, 17% showed increased exhaled NO. And if you look at those patients with more severe symptoms, rhinitis symptoms, almost half of them had bronchial symptoms. Well, we really should intervene and attack early the problem. And I think that this study is very important. The PAT study, Preventive Allergy Treatment Study, well, it has been criticized because it's not fully randomized. It's randomized, but it's not placebo controlled. But I think it's showing the way. If you treat rhinitis early enough, you can decrease at the five-year point. You can decrease the occurrence of asthma about 50%. Maybe the magnitude is somewhat too high, but I think this is showing the right way. But then I would like also to tell you that, like Sergio was speaking about the systemic atopic syndrome, that don't forget as pulmonologists, especially as pulmonologists, don't forget the atopic dermatitis, because many of them really have increased bronchial responsiveness and asthma symptoms, but if they have a severe dermatitis, they are prone to forget their airway problems if they are not breathless. Well, here you see two young people who is at risk to have asthma in future. It's him here. This boy has a severe type of dermatitis, and I can tell you, if you see severe type of dermatitis, half of them have increased bronchial responsiveness. A group in our hospital made a study where these kind of patients with severe dermatitis, moderate to severe dermatitis, they were really treated effectively, early and aggressively with a new immunomodulative treatment by tacrolimus ointment. So at baseline, 31% had 31% of the eczema, the body surface was covered with the eczema. After the treatment year, 11%. So that was very effective against the dermatitis. But it was also very effective to the respiratory symptoms. The bronchial symptoms went down when we look at the visual analog scale. The rhinitis symptoms went down. And also, and that was a kind of a surprise, that bronchial hyperactivity, which at the first place was observed in 51%, was only observed with the very standardized method after the one-year treatment in 37%. Even though we didn't change their respiratory treatment at all during that year. So treat the whole atopic syndrome. And then lastly, treat all aspects of inflammation and do it early. And I'll just give you, I think, a very, very convincing example, because it's really a community effort in Finland. The National Asthma Action Program, which was not just that the old professors go to the pub and take a beer and say that this is the way the asthma should be treated and go home and hope everything is fine. No, that was an implementation program. It was really not only looking retrospectively, but prospectively. A 10-year action program. A community problem needs community solutions. And we have just now submitted the 10-year document. Well, the principles are simple. Start effective anti-inflammatory treatment early, win the patient's confidence, and improve the outcome. Treat the exacerbations early. Educate the patient, not just tell what to do, but give written self-management plan. And of course, more self-evidently, treat according to disease severity. Well, what has happened? We have really created a network, about 800 doctors in health centers and asthma nurses, and also about 500 pharmacists in pharmacies who work together to detect the problem early and attack and intervene asthma with anti-inflammatory medication as early as possible. And here is the result. We have not been able to tackle the steady increase in asthma prevalence. That is the major change for the future. But that is what we are trying to explore when we are comparing the Russian and the Finnish Karelia. What is causing this epidemic? This remains a challenge. However, when you look what has happened to these asthmatics, and this is just one example, there is a decrease in the disability pensions and days of work, 80% in 10 years' time, from 1994 to 2004. They are doing fine, mostly they are doing fine, they are working, they are living a normal life, and this is because of early detection and early treatment. Well, then very, very new data. Very, very new data. What has happened to the costs of asthma? Here in 1993, the total cost for asthma was in Finland 218 million euros. And now, 10 years later, 213 million euros. I think this is the first time that some nation has been able to show that the costs of some disease has gone down. We have been able to halt the increase in the cost, and that was a big worry at the beginning, and that was one of the reasons why the Minister of Health and Social Welfare were with us, that just cut down the costs. So we cut down the costs, but then if you look at the proportions here, the decrease in the disability, it has a major impact, but then look at the drug costs. The drug costs, they have come up from 40 million euros to 80 million euros. They have doubled during the 10 years' time. And now comes the very, very academic part of this speech. This increase in drug costs is mainly caused by 4S, Seretide, Symbicort, Singulair, and Spiriva. Have they, and I am just now saying this as a professor without any connections to anything, have they really contributed these 4S to the success of the Finnish asthma program? The very simple answer is probably not. This is not the case of most of the increased asthma drug costs are, in a way, if you take the public health view, unnecessary. It's much more necessary that you detect the problem and you treat them early, and it doesn't matter what steroid, for example, you are using. Then again, if you look at the costs per patient, 1993, 1,611 euros per patient per year. And now it's 1,031. We have been able to put down the per patient costs by 40%. And if you take into account the domestic national product, in fact, we have been able to put down the cost per patient 50%. They don't need the medication and all that. They are working, they are not in the hospital, they visit their doctors, and that's why this proportion has been increasing, and that's okay, that was our aim. Well, finally, SOMA study, and this is a proof of concept study. Forget that this was made by Sembicort. Forget it. This was a proof of concept, and my message is that even in the GINA guidelines, step 1, where you have intermittent symptoms. You know, intermittent symptoms, mild persistent, moderate persistent, severe persistent. And now I'm focusing on mild intermittent. Maybe in Finland, those who are wheezing during the first pollen season, maybe who are wheezing after the respiratory infection for a few weeks. But most of the time they are okay, and their lung function is also okay. So we did a study where we compared, and there's no maintenance treatment. The patients are only taking Symbicort, the fixed combination, as needed, or Oxys, the formoterol, as needed. And the whole point was to show that in these very early stages, with this intermittent stage, they already do have an inflammation in their airways. I am not recommending Symbicort or Seretide to the mild type of asthma on regular basis. But let's look at the result. The primary outcome, because we were interested in inflammation, the primary outcome was NO. And let me add that on average, for the whole population in this study, they used 0.8 inhalation per day. 0.8, less than 1 inhalation per day. And that was totally up to them when to take the inhalation. So here you see that in the budesonide formoterol group, where they always, when they kind of tried to find where is my blue inhaler, they also took an extra anti-inflammatory medication. Kind of when you are trying to find your blue inhaler, what does it mean? It is a mini exacerbation. It's a small exacerbation. The inflammation is coming up. So the NO went down. When in the formoterol group, nothing happened. The difference in changes was 15.5 ppb. And the p-value was very, very high. And this has been our idea in Finland, in the asthma program. Attack it early. The inflammation is the first thing to take place there. Detect it early, and you will have a very, very good result. Here are my take-home messages. The epidemic of asthma and rhinitis is leveling off in affluent countries, but it's only taking off in developing countries, and that is a really major challenge. Think about China, India, Indonesia, Africa. Asthma and rhinitis are chronic immunological disorders and eventually should be treated as such. Exploring genetics is not really helping the clinician for years to come, but it's of course increasing our knowledge a lot, and it will help sometime in future, but we have to wait for years. Sorry to say that. Early detection and treatment of inflammation is highly successful, and I refer to the Finnish experience. Ladies and gentlemen, it was a pleasure to be with you. Thank you very much.
Prima facciamo alcune domande su quest'ultima relazione, poi apriamo la discussione generale. Well, if I may make a comment, I was glad to invite you in 1988. I'm even more glad to have you here this time. E grazie per essere venuto. Steve Holgate, first question, up there on the right. Welcome, Steve.
Thank you, and thank you very much, Terry, for weaving together such a fascinating talk, bringing epidemiology, clinical science, genetics, all together, as well as a brief glimpse, I think, of your butterfly collecting, but I'm not sure. Tell me what you think, honestly, about whether inhaled steroids influence the natural history of asthma?
Thank you very much for that question. I'm not sure, to be sure, but you must differentiate a few things. If you have a symptomatic patient in your office, the first question is, what is the right way to treat the patient to get him asymptomatic? And this is give the anti-inflammatory. And don't kind of wait for weeks or months or years with beta-2 agonists, with expectorants, with antibiotics, with antihistamines, with antitussives, and whatever, which are not really affecting the basic inflammation. You get happy patients, and you get the result, what we see in the Finnish asthma program. Then another question is whether it really prevents the decline, for example, of lung function, which we see in population studies, or the remodeling process. And that is a very tricky question to be asked. You need tens of thousands of patients, and you need long-term follow-ups. And I'm not sure whether this is ever going to be shown. And then a third thing is that when you are looking at those long-term studies, it's very much also dependent what you are looking. Are you looking at the pre-bronchodilator values, or are you looking at the post-bronchodilator values? If you look at the pre-bronchodilator FEV values, for example, I think that we even have a possibility to show that there is it prevents the decline of lung function in long term. In post-bronchodilator values, it's more difficult. This is going to be an academic argue for a long time to come, but there is no question that in practice it works superbly, and that's how it should be. Steroids are not the only anti-inflammatory. There are leukotriene antagonists which are fantastic in many patients. But there is, of course, a little problem with them that about maybe 30% of the population or the asthmatic population is not really responding. But when it matches, it may be even a magic bullet. And leukotriene antagonists, they are anti-inflammatory.
If I may get into the discussion and maybe to extend, not for direct experience, but because I had the opportunity to and to look at the literature, my simple answer would be no. I mean, we have no evidence that not only steroids, but particularly steroids, because we did hope that steroids, by definition, could affect the natural history. I think that there are a few studies that, in fact, show that they are symptomatic like the other drug. I mean, obviously, you are much more reassured because along with the clinical and functional improvement, you have also the pathological changes. But we have to rethink about the entire concept. If the question is, do we have an asthmatic who becomes non-asthmatics after any of the treatment we have available? The answer is no. Do we have any treatment that prevents long-term decline in any of the parameters that we have? The answer is even no, unfortunately, because the study in children in America and even even the Roman Powell START study showed that after 3 or 4 years of treatment, lung function goes back to that should not, in fact, discourage us from implementing, and I hope that my Italian colleagues, and I'll briefly summarize the message of the last few slides, that should not discourage us from implementing plans like the Finnish plan that in fact, benefit the patients. And I'm very happy that, in fact, I reinforce the message of Steve in thanking you because of you put together science and public health in showing that, in fact, translating the results of the experiments to the clinical practice, you obtain beautiful results. Per tornare a noi, le ultime diapositive sul piano sanitario sull'asma fatto in Finlandia, che è stato esteso anche, ne aspettiamo i risultati con trepidazione, alla COPD, è estremamente interessante il fatto di aver implementato un piano molto semplice, a volte azzardato e criticato perché non completamente basato sull'evidenza scientifica. Sulla base di quello magari non si riesce a modificare l'epidemiologia in termini di prevalenza, ma certamente il fatto di avere ridotto i ricoveri, di avere ridotto il numero di giorni di perdita di scuola o di lavoro, cioè di avere modificato la qualità della vita dei pazienti e di aver dimostrato che il trattamento precoce e appropriato di questi pazienti ha portato a un aumento sì da una parte del costo dei farmaci, ma con prova provata di una diminuzione dei costi sociali e della qualità della malattia, secondo noi e secondo l'OMS, i piani finlandesi vengono presi a modello nell'ambito dell'OMS CARD come piani da applicare.
Sorry, do you hear me? Yeah, okay. I would also like to add that we have been speaking about remodeling for, well, it is something which is happening. There's no question about that. If you take the general population and take the asthmatic population, decline in lung function is somewhat larger in the asthmatic population. But then you have to kind of split it up, because 70% of asthmatics, they do have a mild disease. They have a mild intermittent or mild persistent. It's a small proportion who have really the moderate and severe asthma. And we are more focused on that end of the spectrum in our clinical studies and in all our guidelines, because most of the studies have been done in that proportion. Meaning that the remodeling is not clinically that important issue in the mild patients. It doesn't matter if your peak flow value, which is now 500 liters per minute, whether it's after 10 years it's 470 or 480. It doesn't really make a change. So the remodeling also, to have the effect, whether steroids do kind of prevent remodeling and prevent the decline, it should be focused more on those patients who really have this phenomenon, or who we can predict that really have this phenomenon. And this has not really been made. It is kind of the result comes diluted very much about the mild, in some studies with the mild and intermittent patients who don't have this issue really taking place so much.
Sorry. We cut the discussion to Sergio just to give him the opportunity to comment on the general discussion. Sergio, would you like to enter into this discussion? Yeah, this, I mean, general issue.
Shall we have it in English?
There is a simultaneous translation in Italian.
May I first comment on these last words by Tari? Tari, I fully agree with you, but I guess that we are still talking about asthmatics. And unfortunately, we do not have yet the markers to define the phenotypes of asthmatics. Because what I think is actually that remodeling is an event that is maybe affecting not all the asthmatics. So in other words, what I mean is that maybe that we should define, I don't know how now, hopefully in the future, the most susceptible patients to one kind of treatment, for instance, long-term continuous treatment with steroids, with antileukotrienes or whatever, you know, and maybe this is a different population of the one that you have to treat in a different way. And maybe that in the second one, just as needed treatment, because the remodeling, let's say, hypothesize that because the remodeling is not so important actually in the disease. That's the point.
We have just tried to get published a very important study, but which seems to be a problem with the referees, because they don't like the idea that in children you can very often go to intermittent periodic treatment. And what we did is the pediatrician Markku Turpeinen is the first author there. And what he did was that he took school-aged children who had a pretty newly detected disease and treated them aggressively for 6 months with anti-inflammatory medication. So they were almost symptom-free, their lung function was normal, and then they were randomized to 2 treatment groups. The one was having a small dose of steroid, 200 micrograms of budesonide for 1 year, and the other one was randomized to only take budesonide for 2 weeks if they felt they had a kind of an exacerbation or their mothers felt that. So what happened? We expected that those with the small dose of steroid would do better. Well, they did, but the difference was very, very small, telling us as clinicians that in children, if you detect them early, if you treat them effectively for a few months, most of them probably could go on with intermittent treatment. But of course, in that population, you have to be careful, because there are children who are not coping with that, and you have to put them on continuous steroid. But my idea is anyway that we should not over-treat the patients. We also are facing a problem of over-treatment. We are giving them sometimes too much steroids. The doses may be too high. It's too continuous to treatment. Maybe we can do with less treatment. And also, we are very much now with the fixed combinations. We are giving them beta-2 agonist on a regular basis, which I very much doubt is useful for all asthmatics.
Any other question or comment from a general point of view on the aspects that...
One stimulus for our pediatrician today, I don't want to discuss it now, is are we ready for intermittent treatment with anti-leukotrienes? But keep it, hold it, because I think there will be interesting data presented.
Thank you for your fascinating talk. You show that some cells express the G protein-coupled receptors. We know that antihistamines, especially the new generation antihistamine, work mainly linked to these receptors. So my question is, according to what Sergio Bonini said in his previous talk, do you think that this finding can help us to select some specific subgroups of asthmatic patients that can respond better to antihistamines?
I think this is a very, very crucial question, and I certainly feel and think that this will be the case. And we will be able, in 5 to 10 years' time, we will be able to find these subgroups by genetic analysis who will respond to leukotriene antagonists, who will be resistant to steroids or more or less resistant, because full resistance is extremely rare, who will be really benefited by antihistamines. I don't argue with that. Antihistamines are, in a way, anti-inflammatory. In most of the asthmatic inflammation, the effect is, unfortunately, too weak. But you can find patients in whom the atopic condition altogether will be very much controlled just by antihistamines. It's possible, but they are on the mild side of the spectrum.
Before we go to more general aspects, I had a specific question for your talk. I was very much interested of these macrophages, expressing GP R15-4. I should like to know what is the phenotype of the cells in terms of pattern antigen recognition receptors, and have you looked at the influence of toll-like receptor stimulation? Do they are an overexpression of toll-like receptors, or?
Induced sputum samples in which I showed you, they are just taken from ordinary asthmatics. And their macrophages seem to overexpress really this protein. But it's just, everything after that is more or less of speculation.
Thank you for your very nice presentation. I have a practical question. You have mentioned about the possibility to use induced sputum and exhaled nitroxide to distinguish between eosinophilic asthma and non-eosinophilic asthma. I would like to know what is your approach with the asthmatic patient with low nitroxide or no eosinophil in the sputum. I'm a pediatrician, and as you know, in children it is difficult to obtain induced sputum, so more often we use exhaled nitroxide. Do you think that just exhaled nitroxide is useful to distinguish between eosinophilic and non-eosinophilic asthma?
Exhaled NO is not specific, but it correlates quite well with eosinophilic, with the increase. That has been shown in several studies. But I have one warning, and that is the atopic syndrome. You may have a patient who is having atopic dermatitis, who is having rhinitis, and then you measure the exhaled NO, and it's sky high. And the asthma symptoms may be very, very few, or almost symptom-free. Don't ever treat NO, treat the patient. It cannot really distinguish eosinophil inflammation from non-eosinophilic inflammation. But in patient population studies, the correlation is pretty good. So if you find an increased NO, and then you find other risk factors by just asking the patient, do you have family asthma, is there signs of atopy, or whatever. So it seems that it is very likely that this increased NO is associated with eosinophilic type of inflammation. But if you really want to make a specific diagnosis, you have to make the induced sputum and find out with the soluble inflammatory markers whether it's really a neutrophilic or an eosinophilic or a mixed type of inflammation. But we are having that possibility I think, in a few years' time. In children over the age of 5, the success rate in our hands for induced sputum is around 70–75%. In adults, it's near 90%. With exhaled NO, the success rate is, of course, higher.
Trying to put together your beautiful data with the underlying inflammation. You said treat early, any drug, any anti-inflammatory drug is good, and treat intermittent asthma with the drug as needed. We know that inflammation is there even between attacks in the interval periods. So, as you said, this as needed fashion is like a little exacerbation, you treat the little exacerbation, and then the patient is doing very well. So I think this is a good example of what we were saying before, Leo. We are not treating the underlying baseline exacerbation and remodeling. We are really not doing nothing to that. We are doing something in the little change that is happening during that moment. And by doing that, just by doing that, we are changing the history and the course, not the natural history, but the clinical approach and having this good result that you showed. So I think we shouldn't have the idea that we have to act necessarily on what's going on the baseline conditions. Probably it's not necessary to do that.
Yeah, there are studies which show that in patients who seem to be asymptomatic, so who are clinically doing fine, young people who have, for example, grown out of their childhood asthma. If you look close enough, you find the signs of small inflammation. They are not really fully normal. But then again, you always have to think that the inflammation and the whole asthma business, that is a balance in the body and in the immune system. The same cells, the mast cells, they are producing the cytokines and mediators which cause the inflammation, but the very same cells are also producing the anti-inflammatory agents, the heparin, the proteoglycans and all that. Again, I feel, and going back to what you said, that we don't have any very hard data that steroids are really changing the course, that we, and this is reassuring us that we should treat the patient early and in a right way, but there is no idea to put him on regular high-dose steroids for years in the idea to prevent some possible decline in the future. But I am not saying that patients should just use, for example, anti-inflammatory medication as needed, meaning that take one inhalation today and one inhalation after 2 days and whatever. I very much recommend, and that has been our recommendation also in the Finnish asthma program, that when you start with anti-inflammatory, treat the patient at least 2 weeks. Give the at least 2-week period, and then if the patient is fine, so in practice, from 2 weeks to 4 weeks. And then if it's a mild disease, intermittent disease, you can follow the situation. And this has also been, we have applied this idea to perennial rhinitis. And Juhani Rinne from our hospital published a paper a few years ago in Journal of Allergy Clinical Immunology showing that after regular rhinitis treatment with budesonide, during the follow-up year, the patients with perennial rhinitis could cope with, on average, 4.4 2-week treatment periods. And they were pretty fine. So this is telling us that we have to individualize our treatment, and we really should think about our patients as individuals. There are no regulations which suits all.
Mi spiace che forse il problema della lingua non permetta di discutere le ricadute pratiche di questa discussione e a volte quando c'è un dibattito in inglese viene un po' tarpata la discussione pratica che invece questo corso vorrebbe avere. Vorrei, da una parte, ho 2 domande che volevo fare, ma vorrei darvi la possibilità, per quanto possibile, di magari se non c'è l'occasione di fare le domande in questa sede, voi le mandate per posta elettronica all'indirizzo che vi verrà dato e noi risponderemo, chiederemo risposta agli oratori alle domande che avete sugli aspetti pratici. Now I have to switch back to English, and the question is, you, Steve, and you, Tari, and the discussion, I think, focus on 2 aspects. One is what do we do with the biomarker? And you, Tari, had a sort of negative message now. You say treat the patient, and I agree with you. However, we had a couple of years ago a quite interesting lecture by Ian Pavord on phenotyping, both of asthma and COPD. And he felt, based on his own data, that we are almost ready to phenotyping patient based on sputum eosinophils, for instance. And by doing that, you might reduce the amount of steroids. Those with few eosinophils not to be treated aggressively with steroids on the other. The other point is, and which is the same on the same line, and that's a very practical question. I tend to agree with this attitude. I treat the patient, not the biomarker. There is one biomarker that for some reason I cannot resist not to treat. That is circulating eosinophilia. Anytime I see a circulating eosinophilia above, let's say, 10 or 15%, I am tempted, and I cannot resist, and I try to resist, I cannot resist to treat more aggressively, particularly with oral steroids, because I'm worried about the Chuk-Strauss. I know that is not evidence-based, but may I ask, what the experience of the clinicians in the room about these two approaches?
Well, I certainly feel you are on the right track, as always, Leo. If you have increased numbers of blood eosinophils, it's pretty severe inflammation, which is good. But you often see that you have inflammation on the mucous membranes, in sputum and bronchial, even bronchial biopsies, but the blood eosinophils are normal. But if the blood eosinophils are really increased, well, okay, it's again depending the symptomatology, but anyway, I would be more alert to treat these kind of patients with persistent treatment. Yeah, I think we are really heading also this era that we are able to differentiate really an eosinophilic or neutrophilic or a mixed type of inflammation. And when we have now several studies which have shown that if we use and monitor some of these biomarkers like XLNO, that was published this year, or sputum eosinophils, if we use some biomarker of the severity of the inflammation to guide our treatment decisions, we get a better result. And that is very, very important clinical message. We should more and more not only measure the functional element, but also the inflammatory element.
Nella mia esperienza, i pazienti con eosinofilia, anche trattati con steroidi inalatori, la eosinofilia si riduce in tempi abbastanza precoci. Mi chiedo perché tu sollecitavi un trattamento per steroidi per via generale.
The reason that I have in mind, I have the photograph of at least 5 patients, women, average 16–20% circulating eosinophils that do not go down even with high-dose inhaled steroids. And I have no reason, there was no, if you look carefully, you find everything you want. So sometimes they have some paresthesia, maybe they had one pneumonia, they may have some skin that may be related, but I'm really don't have a specific. But for some reason in this patient, I'm counting, the number. I don't see many patients, but I do see some patients. And I have these 4 or 5 mainly ladies, almost only ladies, that are always constantly with this kind of value. And that's the only reason. They don't go down using even very high inhalation. Any other comments?
May I comment on that? I think perhaps you should distinguish. If we accept the concept that the message go from the target tissue to the bone marrow, and then this influence, I think you should accept that topical steroids should affect also systemic level of eosinophils. So this is the case you say. If there are some cases where you have over 10% and topical steroids are not effective, I should think that the message doesn't come from the lung. Also because, in my experience, if you go over 10% or let's say with a normal blood count, I think you should suspect something different. So you can have a specific phenotype of asthmatics who have perhaps something else. But I don't know whether you have to accept that if you accept that in asthma, where you can have an eosinophilia of 4, 5%, 6%, depending, I think you should expect that topical steroid. So I agree with you that when you find subjects who do not respond to topical, have a quite important eosinophilia, you should look for a phenotype of asthma associated with other diseases.
Thank you. Lunchtime. Lunch is served upstairs. Ringrazio il pranzo sopra. Ringrazio gli oratori, Haathtela from Helsinki, Finland. Sergio Bonini, Walter per la eccellente mattinata e ci rivediamo.